I got my qualifications in 1980 and sort of fell into a research career at Flinders University. And then the 1983 Ash Wednesday bushfires happened, and I'll never forget it. I was sitting around with my now ex-wife. Our firstborn son was about 3 months old, and I said, well, I'm looking forward to a quiet year. And I got this phone call from a senior colleague who said, would you like to come and help write a report for the Minister of Health about the impact of the 1983 Ash Wednesday bushfires? And that was the most telling and dramatic phone call I ever received in my life, because my mother's family were all primary producers, and my brother was a farmer down in the southeast working for the Department of Agriculture. So I had sort of like a natural affinity for the predicament of the farmers who'd been absolutely sort of devastated by those fires. And it became an absolute privilege to work with those communities over a 7-year period, where I would have seen over 300 of the people affected by the fire as patients. But I also came to understand the need for a great deal of research, because PTSD had only come into the diagnostic systems in psychiatry in 1980. And disasters was one of the areas that it was seen to be very important. And I did a study of all of the disaster victims. I did a study of 800 primary school children in the southeast of the state, and also of around 600 emergency firefighters, the country firefighters who were essentially volunteers. I then became involved in the litigation, because those fires began because of the power lines in the heat on this very windy day being slightly out of phase, and then they would strike each other and created all these ignition points, which is one of the reasons why it was such a devastating fire. Mm-hmm. So since then, my life essentially has been one disaster after another.
Welcome to Deep Thinking with Dr. Stephen Stolz, where academic rigour meets real life. I'm Dr. Stephen Stolz, educator, philosopher and academic at the University of Adelaide. And this podcast series is my quest to help everyday people access research-based ideas that feed curiosity and foster deep thinking. In today's episode, I explore the complex terrain of post-traumatic stress disorder, or PTSD, with one of the world's leading experts in trauma research and treatment, Professor Sandy McFarlane. Professor McFarlane is Emeritus Professor of Psychiatry at the University of Adelaide. He is an international expert in the field of the impact of disasters and PTSD. He is a recipient of the Lifetime Achievement Award of the International Society for Traumatic Stress Studies for outstanding and fundamental contributions to the field of traumatic stress studies. He has held roles as Senior Advisor to the Australian Defence Force and the Department of Veteran Affairs. He has advised the South Australian and New South Wales governments about the recovery after disasters. He is a retired Group Captain of the Royal Australian Air Force, Special Reserve. He has published over 480 articles and chapters and has co-edited 3 books. Whether you're a healthcare professional or someone affected by trauma, or simply just curious about the human mind's response to extraordinary circumstances, then this episode is for you, as it offers valuable insights into one of the most challenging psychological conditions of our time. So join me as I bridge the gap between evidence-based research and everyday application. This is Deep Thinking with Dr. Stephen Stolz. You mentioned the PTSD didn't become part of the DSM manual until 1980. Have I got that right? Just tell us a little bit about, I guess, some of the history around PTSD, just understanding a little bit more about some of the historical aspects here around PTSD, and even before that, World War I, and it was shell shock.
Well, look, the history of this field is an extraordinarily interesting one. And look, one of the privileges about working in this field as a psychiatrist is it's not sitting in an office consulting with people. It's about communities. It's about the way that major events change society. It's about the way that societies care for people who've been through terrible events, are protected and thought about by the community. So the history of it really covers those issues. Now, one of the intriguing things about trauma is that stress is on a continuum from events such as, being under financial stress or having relationship difficulties or losing your job, through to events such as terribly threatening life, endangering events, accidents, war, also interpersonal violence, murder, rape. And one of the intriguing things about the events that sit at the extreme spectrum is that often people struggle to describe those experiences in language. At the age of 16, I played Macduff in the play of Macbeth, and there's a scene where Macduff discovers the slain body of King Duncan and his bodyguards, and Macduff runs down the stairs from the king's chamber and says, "Oh, horror, 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 tongue nor heart can conceive nor name thee." Now, I wish that as a 16-year-old I understood what that meant as I do now, because one of the things about horrific experiences is that they are beyond language. So often when you speak to people, in the intimate setting of a consultation, they absolutely struggle to find words to explain their response, the reality of what occurred. There's often a terrible state of confusion. So I think these are basically experiences that overwhelm the mind. And I think as a consequence, even literature didn't really encompass the reality of often what people have suffered. In fact, some of the greatest works of literature, like War and Peace, are in fact an exploration of trying to bring these sorts of experiences into some sort of linguistic discourse. Now, the consequence, I think, of these experiences not being easily communicated, and I think often not being understood equally by the listener, is that I think there was a huge lacuna of understanding and knowledge in psychology and psychiatry about the impact of these events. One of the great ironies, actually, is that in 1890, the term traumatic neurosis was coined. And really that is the antecedent of post-traumatic stress disorder. And that arose out of a very interesting period of about 30 years after the introduction of railways, where there were all of these accidents. You'd think it would be a pretty easy thing to have a railway track and not having two engines going in opposite directions at the same time. But it took a while to get that one right. And so there became a whole body of interest in compensation for accident victims. And in fact, that was one of the things that was part of the unification of the German state, interestingly. And originally they thought these were physical injuries because people who'd been traumatised have a whole host of physical complaints. But it was decided that really this was due to the shock to the mind. Now, Freud was part of a group of neurologists who took a great interest in traumatic neurosis, and they came to also see that there were people who'd been terribly abused as children who developed dissociative states like hysteria. And there was a very famous neurologist called Charcot in Paris who used to hold these symposia and there was a tremendous discourse around these ideas, and that's what Freud's original writings were about. But he came under such criticism for believing in the prevalence of sexual abuse that he actually gave up the idea that these had actually been real traumatic events and turned that into the Oedipal fantasy. So, the interesting thing was that society, when confronted with the reality of the horrors that people had been through, couldn't believe it. World War I came along, and in fact the conceptualisation originally was that it was due to the concussive effect of the shells in trench warfare. In fact, people don't realise it. In fact, more people died from shelling rather than the extraordinary frontal assaults that occurred in trench warfare. And
hence the term shell shock.
Shell shock.
Yeah.
But then there was a whole inquiry into this, and the view was that in fact it wasn't due to shell shock. And one formulation actually was because the medical profession was being too kind to the soldiers who broke down in battle. And it was thought to be due to suggestion. And then after the war, the numbers of people who were disabled because of the psychological effects of warfare increased. And people thought they were all going to get better once the war had ended. But in fact, the problem got worse. So what they did then was to blame compensation and said it was because we were compensating people who were psychologically disabled, and it was decided before World War II there would be no compensation for psychological injury.
Wow. Like you're somehow enabling them.
Yeah.
Wow.
And so you can see there was a great deal of prejudicial thinking. World War II came along, and despite those steps, the same problems recurred. In fact, many of the lessons that had arisen from World War I were forgotten, and took the first year of the war, World War II, to relearn the lessons of the probability of high numbers of psychological casualties, because there had been this sort of denial of the reality of the horror of war. And particularly the Americans developed some very effective systems of forward care. But again, they thought that once the war was over, the whole problem would go away because they'd got forward care so well worked out. Interestingly, the Germans denied the existence of psychological injury in World War II, and a military psychiatrist colleague from Germany reckons they probably shot about 46,000 soldiers.
Wow.
In World War II, because people often don't realise that the first people that the Nazis tried to get rid of were not the Jews; they were psychiatric patients. So there was an extraordinary intolerance in the German forces. So at the end of World War II, people really were left with these same sorts of prejudices. And
were they using the same terminology then around shell shock or other colloquial terms?
Well, they called it combat stress reaction.
Combat stress, okay.
They were again not anticipating the long-term consequences. But interestingly, there was a whole generation of psychiatrists after World War II. These were mostly men, of course, at that era in the armed services, who used their military experience to develop an interest in stress more generally. And the whole body of stress research, which is very much part of the modern vernacular, came out of these psychiatrists who'd been interested in the acute effects of warfare and crisis intervention, for example, and short-term psychotherapy and group therapy and therapeutic communities were all developments that came in the aftermath of World War II. But the extraordinary thing was that they still didn't grasp this issue of the terrible long-term impact. And it was because of the world of silence that so many of these patients lived in. Now, what changed that was the Vietnam War. Because the veterans were often treated with contempt if they broke down. It was put down to personality disorders. And the American military thought they'd solved the problem by having a limited tour of duty of 1 year. By limiting the exposure, it was going to solve the problems of long-term stress. And the veterans community felt so disenfranchised by the psychologists and psychiatrists that they formed these rap groups. And interestingly, they joined with the women's movement, who at the time were also arguing about the effects of sexual violence and how poorly that had been managed generally by the medical profession, including sort of other forms of child abuse. And the other group who became very strong advocates was the victims of violence, and particularly the victims of murder, or the families who were the victims of murder. And so it really became a very important social movement, and it was out of that interesting coalition of these different groups that the whole notion of post-traumatic stress disorder and traumatic neurosis came alive. And what was really important about that was that some of the key people were actually psychiatrists generally themselves who had suffered terribly. I mean, there was one very interesting man, Leo Eitinger, who was a Norwegian doctor who, at the age of 30, his family were Austrian Jews who had migrated to Norway. He was captured by the Germans, taken to Auschwitz, and where he was working as a doctor. And he was able to calculate on his 30th birthday that he had a 3% chance of being alive in a year's time.
Wow.
Now, he went back to Norway and taught a whole generation of Norwegian psychiatrists about the impacts of the experience of the concentration camp. They also studied the effects of the Norwegian sailors who had manned the Atlantic convoys. And I never forget actually interviewing him once and him saying that, you know, if he hadn't been able to work to try and bring alive what he'd experienced himself, he thinks he would have been crippled by what he'd been through. And so there were a number of people like him, including some people who'd been in the military in Vietnam, who saw the reality because they'd felt it, experienced it themselves, and they were able to, walk that line between using their own experience and their professional training to really bring about this world of advocacy.
That would make sense with the timing of 1980. So the activism post, around Vietnam, post-Vietnam, that would account for that period of. So am I right in understanding that it first appears in the DSM in 1980? I've got that right?
That's correct.
Yeah, and so you would say the activism led or driven by psychologists, psychiatrists certainly contributed to at least its first entry.
Very much so.
That's interesting. And all right, that's an excellent segue now to my next question around common symptoms of PTSD. Now, we'll do a deep dive here inevitably for those who are listening, but there will be listeners now who'll be wondering, okay, what's some of the common symptoms of PTSD?
Well, look, the first thing about PTSD is that it's a condition that can only be diagnosed if people have been exposed to particular types of terrible life events. Now, I think that's a very important issue because I think the word, look, this is a movement that's become extraordinarily successful to the point that I think that the word trauma gets overused. And I think understanding where that boundary is important, but it's actually included in the diagnostic criteria. Now, one of the interesting things is that the second definition in DSM-3R was that these were experiences outside the range of normal human experience. Now, what that told you was that things like rape, sexual abuse, experiences of war occurred to a very small minority of people. Now, once people started doing good epidemiology and I was very much part of that world in my academic career. We came to realise that, in fact, more than 50% of people had been exposed to these sort of events. So
that's quite high.
Yeah, so these are not events that are outside the range of normal human experience. The extraordinary thing was that psychologists, psychiatrists, doctors hadn't actually registered the prevalence of these events. And it's about the whole idea of speechless terror.
Yeah.
And that people didn't have the language to talk about it. The textbook of psychiatry that I used when I was doing my training, it was published in 1975, said the prevalence of incest was 1 in a million. Now, as a psychiatric registrar at Flinders Medical Centre, I must have seen 20, 30 patients who'd been the victims of incest.
Wow.
And so you sort of knew that this was a world that hadn't been understood, captured, and incorporated in thinking. So, I think this is one of the things that people don't realise is the loneliness and the lack of language, and that's what's stopped people being heard. So the issue is you've got to have one of these experiences that are near-death experiences, life threat, war, and particular forms of sexual violence. So that's the first criterion. But the second thing, really, getting back to your question about the symptoms, it's really what do these experiences do to the human mind? And one of the first things is that normally when we have a life experience, think back to Christmas 2024, you'll have to think, oh, yeah, okay, and you'll think of a location and then you might then construct a narrative. So your brain has to basically seek out when, where, what. What happens with traumatic experiences is that these events don't ever get transformed into memory in the same way that normal experiences do. Because you can imagine it's a bit like a computer that gets overwhelmed by the input of data. It's the wheel of death spinning on the screen. Your mind just gets stuck in the world of this undigested horror. And it might be the smells, it might be the sounds, it might be the pain. And so the first part of these experiences is these recurring horrific images and smells, tastes that can occur in various ways. They can be triggered by things like smells of blood in the environment. If you've been involved in a shocking accident, it might be a particular taste.
So these are the embodied aspects that fascinate me, that a trigger can then, because you mentioned the triggers, that a trigger can then provide this, I understand they call them flashbacks, but you can literally be taken back to that moment and you embody that, you everything that you just mentioned before. So what's going on there that you have this strong embodied response to this stuck memory?
Nietzsche, the philosopher, once said that...
Love Nietzsche. I know a lot about Nietzsche.
That of which we speak is that for which we have contempt, to paraphrase his words. So, I think the extraordinary thing about language is that language allows us to be at a distance to what we've experienced. And so one of the things about these events is that they have never been fully converted into a symbolic linguistic representation. So they sit in these various systems that our brain has of different sensory inputs. Now, sometimes these will just occur spontaneously without triggers in the environment. Sometimes they occur in the form of dreams and nightmares, as well as there being triggers. So that's really the core of post-traumatic stress disorder,
okay.
and it's really what drives the rest of the symptoms. But you can see one of the things about being captured by a particular moment in the past is that you're always looking at the present through something that's happened to you. So you're never actually quite in the present. There's something inside of you that's always prescient and determines the view and the perspective that you have, and it reorientates you through one particular lens to your external world.
Yeah. You see, to me, when I hear you talk like that, it's the sense of self is stuck. It's stuck in that certain moment, and everything in the present and future is from that point of view. Have I got that right, Sandy?
Absolutely.
Yeah.
And so there's several consequences of that. The first one is that, if you've had this experience of extraordinary threat and horror, you're more likely to be constantly vigilant. Your concentration is disrupted. You are more irritable and reactive. Paradoxically, sometimes people get involved in excessive risk-taking behaviour because they lose that ability to sort of separate safety in their day-to-day life. So that one part of the problem is this hyper-reactivity that people have. The other part of it is that, obviously you can't live in that state of distress all the time. So there are other adaptations that occur. I mean, the first thing is that people very actively try and avoid thinking about the horror of what they've been through.
Yes.
The trouble is that if you tell somebody, for example, in a consultation not to look at your tie, of course, the one thing they want to do for the rest of the consultation is look at your tie.
Yes, that's very human. That's a very human thing.
So you can see that avoidance isn't an effective strategy because, in a sense, it just increases your preoccupation with the very thing that you're trying to avoid. So that's one significant part of the problem. The other one is that people try and manage their emotional reactivity by distancing themselves, detaching themselves, going into a state of numbing, losing the ability to experience pleasure. So it's actually that numbing sometimes is the most distressing thing for people because this experience then leaves you as almost as a spectator to your life, and you're not quite sort of engaged in the normal ebb and flow of your relationships and your work and your pleasure.
It's interesting as you talk. I know a few people who have been diagnosed with PTSD, and I've spoken to them just in general, and it's interesting as you talk, everything that you've explained is exactly what's happening to them. And they always tell me about this runaway train. Whenever, like, say there's something that's triggered them, they just get caught up in this runaway train. Like it's like this biological aspect that just takes over their life and their brain disengages. Can you tell me a little bit more about what's that all about? What's going on? What's happening here where they're responding and they have just lose kind of cognitive control, their thinking, and there's this very strong, I'll just use the term embodied, but like a strong biological response that drives just an embodied response. What's that all about, Sandy?
Look, there are different forms of memory, and one of the remarkable things about the human mind is the ability to remember what's salient to the present. But you can see that means that your brain is constantly trying to reorientate yourself according to the current stimuli. So, but it's a bit like even when I use the word stimuli, I don't remember the first time I ever used that word. There's an automaticity to memory. The trouble is that there's one form of non-declarative memory, which is much more about events and unsort of processed experience. And what occurs when people have been traumatised is that part of our memory systems is very easily activated. And what happens is that memory then floods into their awareness, the person's awareness, and in a sense shuts them off from all of these more salient things in the environment. which they should be responding to, because the memory, which has been triggered by something in the environment, then comes to dominate almost the looking out into the world, rather than actually using your memory to make sense of the world coming in. The memory then imposes itself on the external world. So that, and that's when the person then is constantly feeling in this world of trauma in their memory.
Yeah, it's it's interesting because they say if once they are triggered and there's that hypervigilance mode that kicks in, they tell me that they're just gone. That's that biological aspect here, which we're going to get into in a minute. But
perhaps if I can just help to explain that a little bit.
Yeah.
So one of the things about the human brain is it's a bit like a symphony orchestra, where you've got all of these different regions that are working in unison, and we can measure that these days, looking at regional blood flow and also electrical activity. But if you look at the brain of somebody with PTSD, it's a bit like the conductor's fallen off the podium. You know, the first violins are not all playing in time, and they're out of time with the cellos.
Yeah.
And the woodwind section isn't kicking in. So you actually get this fragmentation of neural connectivity. And one of the ways that people can experience that as a mental state is actually dissociation. So people can have distortion of time. You know, they can have distortion of space. And people can really fail to process the reality of their experience. I'll never forget a woman who'd been in a horrific car accident where her car had literally been cut in half. And she had both her femurs, the big bone and the top of the leg were broken. But when she left hospital, she thought she didn't need crutches. She actually hadn't processed the reality of what had occurred and actually couldn't really quite see what the problem was.
Yeah. Wow. This is really amazing. We're going to get to treatment in a minute, I know. Let's go now straight to some of the science here, some of the neurobiological mechanisms that are happening here. Tell us about, we might go to some of the brain, some of the science here now in terms of...
Yeah. Look, I think the first thing to think about here is that, we all go through horrendous experiences, but they obviously in a range of severity. But the survival and the development of humanity is obviously dependent on our brains, and equally through evolution, being able to manage fear response. And equally, we need to learn from fear because there's a tremendous survival instinct in it. And it's not just fear. I think one of the problems with our field, the trauma field, is become too focused on fear, because that fits in with cognitive behavioural theories. But emotions like horror, I think, and disgust, are equally important. But essentially, once you condition an animal to a fear response, that becomes hardwired. You can never undo that. That's been done using sort of animal models where you might condition an animal with a fear response to an electric shock, compared to a light. Now, you can actually train the animal to lose that association, but if you cut the pathway between the frontal lobes and the temporal lobe where the hippocampus and the amygdala sit, that fear response will return. So that tells you that once you've learned a fear response, it's hardwired, and all your brain can do is then to suppress that. And that's why, for humans, our frontal regions of the brain, which are all about judgment and monitoring your environment, are largely suppressing your reactivity. In post-traumatic stress disorder, we know that system doesn't work so well. And one of the reasons why I think often you have people exposed to traumatic events, they cope with them, but particularly as they age, these horrific memories will start coming back, is because essentially the brakes wear out.
You've just answered one of my questions that I had coming up, which is how is it that when a patient presents, say there's an event that happened when they were 19, 20, they've gone their whole 30s, and then something happens in their mid-40s, and then all of a sudden the wheels come off, and then they present with PTSD. So what's going on there? In a way, I feel like you've answered it a little bit, but is that really the answer?
Yes, essentially, sometimes I say to people with PTSD that if you've been through a traumatic event and you try and reestablish your life, it's a bit like driving a car at 60 kilometres an hour. Now, you can drive your car at 60 kilometres an hour with just your foot on the accelerator. You can also drive your car at 60 kilometres an hour with one foot on the brake and one foot on the accelerator. And if you've been traumatised, that's what it's like. And you can see if you're driving with one foot on the brake and one foot on the accelerator, the system is essentially unstable. When you come to a hill, it's much more difficult to get up the hill, and equally, the car's going to wear out. And that's often what happens in that period between an event and when somebody becomes unwell. Those inhibitory systems wear out. The other thing that we've been able to show is that even with very non-trauma-related memory tasks, people with PTSD use many more systems of their brain to decipher relatively simple information. Now, a normal person, if they then presented a more complex task, they will engage other regions of their brain to assist in solving that problem. Interestingly, the people with PTSD are already using those other systems for the simple task.
Yeah, wow.
So you put them into a complex environment and they essentially haven't got the reserves to adapt. So PTSD it creates this sort of internal state of disequilibrium. Now, I've described it in terms of memory functions, but we also know that extreme stress triggers a whole range of other neurobiological changes in inflammatory systems, in neurohormonal systems, and increasingly we're aware that a lot of psychiatric illness is due to neuroinflammation. And one of the interesting parts about PTSD is that people with PTSD are more at risk of getting cardiovascular disease, cancer, autoimmune diseases, and also dementia. Dementia is in part about neuroinflammation. So, PTSD, I think there's actually an argument that we can say it's actually a systemic illness. It affects a whole range of biological systems. And I think it's one of the reasons why it's a pity that, it sort of gets shoehorned into being a psychiatric disorder, because there's a much more sort of substantial biological pathology that undersits it and needs to be addressed when people sort of looking for care and treatment.
Wow. I've got to ask now, this might sound like a silly question, but when you said a memory is stuck, where is it stuck in the brain? What's going on there?
Well, look, I think that's been sort of oversimplified in the vernacular. Everybody talks about the amygdala. Now, the amygdala has almost become almost like an object of abstract art these days. I mean, look, I think it's a term that look, it's an important part of the brain. There's no doubt about it. But we now know that there are many other systems that are critical to the processing of information. See, the interesting thing about your brain is that you, for example, you have light touch, you have proprioception, which is the position of muscles and limbs in space. You've got smell, you've got sound, you've got taste, you've got pain, and any experience you have in your life is not just in one of those domains. So the real question is, how does your brain aggregate all of those different sensations into an experience? And the posterior regions of the brain, the association cortex in the parietal lobes, bring together the auditory inputs, the visual inputs, the musculoskeletal inputs. And so you can see the way that all of those systems are working together is critical in this. Now, emotion in the amygdala is clearly one part of it, but traumatic memory is a lot more than the amygdala, and I think it's it's a simplistic explanation, but you can see it really is about the difficulty your brain has bringing all those things together and then converting them into language, because the unique thing about human beings is the way that we actually distance ourselves from so much of our lives because we convert it into a linguistic form.
I thank you for mentioning the bit about amygdala, because automatically everyone talks about that first and foremost without understanding that there is a little bit more going on when it comes to PTSD. I want to circle back a little bit about some of the science. I'm wondering, and this is a question for you, it's a perfect question for you actually, is the criteria too broad or is it not broad enough?
An intriguing issue, because people who suffer from post-traumatic stress disorder will often also be suffering from severe depression. They might be suffering from social anxiety. So one of the first responses I'd have to you is that trauma isn't just important in the onset of PTSD. It's also a very important factor in the onset of a whole range of psychopathology, including schizophrenia and bipolar disorder. Now, the problem is that academic psychology and psychiatry is very much carved into disorders. So, there's the schizophrenia experts, they're the affective disorder experts, they're the anxiety experts, and then there's the PTSD experts. And so people get very agitated if you start saying, well, actually, trauma is important to all these disciplines, because they then feel quite threatened by that argument and they really want to try and minimise that evidence. But when you think about it, the underlying mechanisms of many psychological disorders are shared. And these sort of events disrupt those systems. Now, the interesting question is, why do some people go down one path of symptom formation and other people go down another path? So, look, I think that's the first issue, is that I think this is a field that has had tremendous relevance to understanding mental illness more generally. The other thing is that actually I had the experience of treating a man who'd been terribly tortured, and in the course of his torture, though he'd nearly been killed, but he became delirious, so began hallucinating, and in his delirium, he started shouting out to in the hearing of the guards, because he thought his brother was being tortured outside of his cell. And he began telling his brother how to survive the torture, but essentially he was giving away to his torturers how he was surviving. Now, interestingly, when he was released, he was more traumatised by being delirious than his torture. When people are psychotic, they might believe that somebody's trying to kill them. Now, the intriguing issue is when they get better, the psychosis has been controlled, that memory of that belief is still there. Now, they might begin to realise it's not true, but you can see the memory of that threat becomes a really important issue. So one of the interesting things that I think, the idea of trauma can do is to begin to humanise our understanding of how the struggle can be to recover from even psychotic illness. To get back to your question about is the field too broad or isn't it broad enough? I think that's become a political and sociological question. Because one of the other reasons why PTSD is a fascinating area because it has all sorts of legal ramifications, and it's very often used in both compensation but also in matters as a criminal defence. And and the issue is about, does it diminish the criminal responsibility of people for their behaviour? And equally, I think that's broadened into the social domain where, people sort of claim to be forgiven for bad behaviour because they say, I've been traumatised by a circumstance. And look, I think in my mind, the use of the term has become, I think, excessively used in that domain, and in an unsophisticated and uncomplicated manner. And look, I think a good, interesting example of this is trigger warnings. Now, we haven't given any trigger warnings before this podcast, and I don't think we should because, look, I think if you're going to talk in reality about this, you have to talk about it in its fullness, and I think we are underestimating the capacity of even traumatised people to manage and survive. And I think by overly dramatising people's lack of resilience and capacity, even those who've suffered enormously, I don't think we're necessarily doing everybody a service.
Yeah, I mean, we were asked to give trigger warnings for all sorts of things today, particularly at the university here. And sometimes I wonder, why are we giving a trigger warning for certain things when I would argue it's not really necessary? So it's interesting to hear you talk.
Well, it's a bit like, the play of Macbeth is now sometimes presented with trigger warnings.
Mm.
Now, surely people must have some anticipation of what Macbeth's about before they go along. And in a way, are you actually evoking excessive reactivity by underestimating people's capacity to see and manage?
Yeah, I think you've answered that question very well there, to be honest. I want to circle back, ask one thing about, you raised a legal question around, if you like, responsibility, I guess, of actions, essentially. I guess legally, I guess it would depend on the circumstance. I realise that, and I realise it also depends on, what the outcome was. But how would that be dealt with, for instance, say, in a serious event? Would there be some recognition or understanding of the PTSD and that may have contributed to a particular event or outcome? So I'm thinking violence here, or an assault, or something like. It's a hypothetical scenario, I know, and you'd probably want more detail, but I guess I'm wondering how that's dealt with legally, because I know you raised that point before, but I'm interested what your experiences are in relation to that.
Well, look, I have been involved in some extremely high-profile cases around this sort of question. And you see, one of the explanations might be, for example, if an individual is assaulted, but then responds in an excessively violent way that leads to the serious injury or even death of the person who initially provoked the assault.
Like a disproportionate response.
A disproportionate response.
Yeah.
Now, see, the issue is if the person who was the initial victim of the assault has previously been in circumstances of a life-threatening assault themselves, from which they've developed a post-traumatic stress disorder, what the initial assault might do is to trigger in their mind the memory of the original assault. So their response is driven by that memory. So they become overwhelmed by the memory of the event that led them being unwell, which then drives their
feel like they're being under attack.
Well, look, and I'm thinking here of a soldier who had been shot and a friend seriously killed in battle, who then is assaulted in a circumstance that reminds him of that battle, and he responds with the ferocity that he would have responded in battle. Now, I've been involved in cases like that where the individual has, been spared the sentence that otherwise might have been passed for if it had been a deliberate act of violence. But it's extraordinary the personal attack that I've come under from people who believe that the court has been unduly respectful of the prior suffering of that individual,
and therefore being too lenient. I can understand that because I think people wouldn't be able to understand essentially what is happening there in relation to the person who suffers from PTSD.
And look, another example might be where somebody is involved in a motor vehicle accident and doesn't stop after that motor vehicle accident. Like essentially hit and run accident.
Yeah.
But sometimes, and I've seen this on a number of occasions, where the individual who's done that has themselves previously been involved in an accident or multiple accidents to which they have had a profound degree of traumatisation. And so those prior events are what drive their memory and immediately organise their behaviour in the circumstance of this most recent accident. So it's one of those intriguing things about how traumatic memories can come to dominate people's awareness and behaviour.
Yeah.
Even though that's not the reality of the current world they're in.
Yeah. Now, I'm glad I asked that question because I'm not going to name particular cases or anything like that, and I certainly don't want you to talk about things you probably can't talk about, but I think there's some interesting aspects here that I wanted to touch on, particularly the question around responsibility. Essentially, that's a question around responsibility and what that means from a legal context. Yeah, no, so thanks for answering that because it's not as straightforward as I'm sure people would like to think it is. And so how courts, I guess, take that into consideration is quite interesting. I'm assuming as the expert, the psychiatric expert, they would come in, you'd provide a report, and I guess they'd ask a whole range of questions. Have I got that right, Sandy?
Yes, yeah. and I've got to say that it's been a great privilege in my career to be involved in legal proceedings because I think ultimately it's the test of academic knowledge.
Barristers would push you pretty hard, I think.
Yeah, and you get the rationale of your thinking gets properly tested, and equally it's probably the venue where, for example, in workers' compensation matters, where systems are held to account in ways that they are not held to account otherwise. I mean, look, I've been involved in a great deal of work with the emergency services and the military, and you can present all this excellent research to them, and so often the systems will do absolutely nothing.
Yeah.
Absolutely nothing. And you've done everything you can to inform and explain, go to court, and a judge makes a particular decision in a particular direction, and that will change the system. And
sometimes it has to come to that, I believe.
Yeah. And so that I think it's very easy to underestimate the value of the judiciary. But, for example, some governments, like in South Australia, have removed the right to sue your employer for negligence. And I think as a consequence, we have lower standards of protection for people like police officers and ambulance officers in terms of the protection of their mental health than occurs in other states. And it's because the government, who is the employer, has removed the ability of those individuals to sue them.
Wow. Do you think, sorry, the skeptical part of me comes out here a little bit, but do you think that's intentional because they know that as first responders, they're likely to report all sorts of trauma-related, kind of incidents, and as a result, knowing that they are trying to protect themselves? Is that a fair line of thinking here, or is that just maybe being too skeptical?
No, I think the people who are trying to protect themselves are the government. Look, I think most people who go into emergency service roles have no idea about what they're going to have to deal with and have no idea about the impact on their health. And look, I would have interviewed over 1,000 police officers and emergency service people And I would say there are very few people where I see them being motivated by the desire for compensation in their presentations. You know, these are people who by their temperament naturally walk towards danger and naturally try and challenge themselves in situation. And I would see so many cases where people have stayed working in those environments when they shouldn't. Now, you know, there's been a great deal of concern in recent times about police violence. Police violence, in my experience, is often perpetrated by officers who are becoming unwell. And one way of dealing with fear is to use aggression. So, in fact, police officers or police departments have, I think, an interest in better protecting emergency service workers' mental health to deal with issues like excessive use of force by police officers. And these are essentially protective and uncontrolled reactions that you'll often see in officers. Yeah,
which automatically, to me, are red flags for PTSD sufferers. To me, that's what I see as well. As in, and I think I agree that there's a duty of care that these organisations need to provide, and I agree if they clearly are suffering, it's probably best that they are not on the front line for a period of time.
As the T.S. Eliot said, humanity cannot tolerate too much reality. And I think when you've been in some of those sorts of roles, there comes a point where it does become intolerable. Look, and I've seen, you know, crime scene investigators who have gone to some horrific crime scene, which they have to observe very closely and intricately, but that crime scene will be triggering the memories of other horrific crime scenes they've been to, so they actually can't fully engage in the investigation of the crime. Now, we don't want people like that working in the front line to solve murders.
Yeah.
So we all have an interest in protecting these.
Agreed. All right, now I've got to ask, this is a big question, and I got to ask it now, and I'm conscious of the time, and we're going to get to intervention strategies, treatments soon. But I mean, this is, to me, is a big question, and so I'm very interested in hearing your response. So, why do some individuals experience a traumatic event and get PTSD, and then others who've experienced the same traumatic event don't get PTSD? I think that's a logical question to ask.
Yeah. That's a $64,000 question. And an enormous amount of energy was put into trying to answer that question, particularly by the Americans in World War II, in terms of selecting people for the military. They tried to look at the spectrum of possible risk factors and to see if you could exclude people who were at risk of breaking down in battle. Now, there's no doubt that there are a group of people who are at greater risk, but the point is there are many people who don't carry significant risk factors who still become unwell. And I think that points to the primacy of exposure to these horrific events as a very potent disruptor of people's psychological health. Now, that's not to ignore your question, but to point out that the effect of these dramatic exposures is something that you can never guarantee a person is going to be immune to. Even the most highly trained, most capable people who go through the selection for the SAS, and I can tell you they have all sorts of personality profiles done on them, and they have a whole range of assessments for potential risk factors. They still become affected. Now, what are the risk factors? Look, the risk factors are people who've previously suffered from a form of psychological distress or mental illness. Now, and that makes sense. Basically, your brain and your capacity to manage has been previously disrupted. So if another adverse event comes along, you're more at risk. There are some, temperaments that are more at risk. People who are naturally overly emotional or more emotionally, engaged and more sensitive are obviously going to be less able to manage, the challenges that dealing with extreme adversity can present. Intelligence, interestingly, has been shown to be an issue. And, I've described how these are extremely complex experiences to integrate. The more intellectual capacity you have, the greater your ability to make sense and survive in situations of extreme demand and horror. People who have certain genetic risks are more likely to get PTSD. Interestingly, the gene for psoriasis and rheumatoid arthritis puts you at risk of developing PTSD. That psoriasis and rheumatoid arthritis are inflammatory disorders, and they're about particular types of inflammatory systems that people carry those. And if you carry those inflammatory systems, you've been more likely to get PTSD. We can also show that if we look at a group of Marines before they deploy to a war zone, people who've got low levels of inflammation are more likely to get PTSD. There's a whole spectrum of possible risk factors. I mean, there's another sort of ironic risk factor. There was a wonderful study that I was peripherally involved with that looked at 2,000 identical twin pairs who were in the American Armed Services at the time of the Vietnam War. And to stop the Saving Private Ryan situation, they'd send one twin to Vietnam and the other twin somewhere else. Now, 40 years later, they'd provided perfect biological controls for each other because, they've got identical genetics. So one of the things that was done in that study was to actually look at what was the personality type that predicted PTSD, and it was the reverse of what you would think, because the people who are more likely to get PTSD were those who were novelty seekers, were socially independent, and weren't harm avoidant, so they would face harm. Now, the interesting thing was, if you had those personality characteristics, you essentially became a member of a frontline combat unit, whereas if you were high on harm avoidance, low on novelty seeking, and socially dependent, you became a cook. And you're more likely to get, it's obvious where you're more likely to get PTSD.
Yeah, wow. Because one part of my thinking was, are there certain specific events that could be a contributing factor? But, and what are your, I'll let you answer that. In terms of, this is obviously in relation to the question I asked about, that is it certain events that can do it? But clearly that's not the case, right? Because here we have two individuals, person A and person B, they're experiencing the same event. So I can understand why the field would be then turning to, say individuals in terms of makeup, personality. And so it's an interesting one you mentioned about the IQ. That's an interesting one. I haven't heard that one before. So some of the other things here, so because obviously PTSD being an environmental related kind of condition, it's a logical question to ask, and I find it interesting that there is no definitive answer yet. Do you think they'll ever find one?
No, but look, I think your other question brings in another whole world.
Yes.
You've got two individuals who carry exactly the same risk factors exposed to the same event.
Correct.
See, the first thing is, these are events that we all bring meaning and interpretation to. And, it's what we see and what we identify with in a particular situation. It's a bit like a soldier who's in a combat zone or a disaster zone or a peacekeeping role. Somebody who has children themselves, if they see a child of the same age as one of their children being killed or injured or suffering terribly, you can see that person is going to be more engaged with the humanity of that situation than somebody who doesn't have kids.
Yeah.
Look, I can remember as a young doctor walking through a paediatric ward before I had kids and after I had kids. I became much more sensitive to the crying of the children once I'd had kids myself.
Yeah.
So I think, the meaning of an event is one critical issue. And often, that comes from your prior trauma exposures.
Thank you. That's a perfect segue to my next question, because my next logical question to that relates to, is PTSD generally connected with a single event or a series of events? Do you know what I mean by that question? Yes. Yeah.
Look, I think the way that the diagnosis is written makes everybody think about a single event, and I think that's erroneous. Look, there's now a great deal of evidence that it's about your cumulative stress exposure, and that's the important issue to think about. With people in emergency service roles and military roles. I mean, the military manage this much better than the emergency services do. You, as a soldier, you're not kept in the front line the whole time. You go on a cycle of training, recovery, deployment, whereas police officers are expected to be in the front line all the time, every day.
Yeah.
Look, sort of cumulative exposure is a critical issue, but that doesn't mean that you can't have an event that is sufficiently overwhelming for that event alone to lead you to become
the stuck memory, the stuck in the moment. See, that's the interesting, because when I talk to my colleagues, friends, associates, who have PTSD, they always talk about, they remember one particular event, which is the stuck memory, so on and so forth, but yet they also talk about other traumas, like as if there are multiple or a series of traumas. And that obviously then led to that question around, what's going on here? Why are they stuck in one traumatic event, which obviously is part of the PTSD diagnosis, but there are other also series of traumas as well. So what's going on?
Well, you see, I think one of the issues is that, and I've proposed that we should have a staging model of PTSD. Like, somebody who's never been exposed to a traumatic event is at much lower risk than somebody who's been exposed to one or multiple traumatic events. And it's because even though you've survived them, haven't become symptomatic, your stress systems have had to accommodate and react. And your stress systems do change with repeated exposures. And part of that is also the effects of ageing. People's reactivity to the event that might finally make them unwell is not independent of those things that have come before. I mean, the other side of that is that, people who've had challenging and difficult experiences in their lives often also learn from them. So stress actually sometimes helps you cope with real adversity because you've learned a set of adaptive skills. I think one of the things about traumatic events is people, and look, I learned this after the Ash Wednesday bushfires, about 40% of the firefighters I interviewed and studied had panicked at some stage. And essentially people panic when there are multiple things that you can do to determine your survival and you don't know what to focus on. Now, you can see somebody who's been through a circumstance like this before will have already thought through that set of choices. And that's one of the reasons why training is also a really important issue in protecting people who are in high-stress roles, because you have a repertoire of choice and behaviour that can allow you to function.
Yeah. It can explain also why in the military they train until it does become automatic, because obviously in combat situations this kind of fallacy, myth that you got all this time to think. That's just, that's Hollywood, and hence why they train you. Also, obviously, you want it to become autonomous, in stressful situations. You don't want to have to think. So I can understand that, definitely. Military, I get it. I completely get it. Other kind of environments, you made an interesting point about first responders. They don't get a break. And so that's an interesting one in terms of I can understand the benefits of training, so on and so forth. And I'm going to come back to that question, if I may, because I will have a question around what you can do to protect yourself with PTSD. But I want to hold off on that until the end because we need to turn to treatment approaches that are found to be the most effective for PTSD. And if I can get you to start talking about prolonged exposure, or PE, eye movement desensitization and reprocessing, or EMDR, neurofeedback, and then any other alternative approaches that you want to talk about. So I might. This is an important part, so I want to make sure we have plenty of time to talk about this. So let's turn to treatment now.
Well, just going back to a couple of things I said before, essentially the core issue in treatment is getting the person to find a way of holding on to the memory for long enough that they can begin to integrate all of these different sensory inputs that form the integral sort of representation of an experience. And you can see how avoidance, if you start thinking about something and you run away from it, you never actually focus on it and master it. So the aim of treatment is to hold the memory for long enough and all the horrific emotions that go with it, and to convert it into a linguistic representation. Because, as I said before, language allows you to be at a distance. It's a bit like sitting in the middle of an interview. When I ask you about breakfast this morning, you don't suddenly get the taste of whatever you had for breakfast. You think, oh, yes, I had such and such. Now, see, the difference between that sort of memory and a traumatic memory is that the traumatic memory, you would have the taste of what you ate. Mm. So you can see that is the core of what treatment is.
Yeah.
Now, Freud actually described that treatment in one of his very famous monographs on hysteria. Mm-hmm. It's holding the emotion and the memory and the event together in the course of therapy. Now, the trouble is you've got all of these different schools of therapy who then claim to be the most effective and valuable intervention. But I think they all build off exactly the same principles. And, for example, exposure-based treatments.
Yep, the PE, prolonged exposure.
Prolonged exposure is where you get the person to hold on to the traumatic memory and to describe it in detail and to focus on the worst moments of the memory. But you can see that's based on the idea that if you can maintain a fear in your mind for long enough, the level of the fear will begin to drop. Mm. Now, I'm sure that's part of what's going on there, but you can see it's also you having to talk about it. So, the whole linguistic processing is part of it. There's cognitive processing therapy, which looks more at the sorts of beliefs and interpretations you make of the circumstance and consequence. Mm. You might blame yourself for the circumstance in irrational ways, etc. Mm. But again, you can see that still is holding on to this experience. I mean, EMDR is one of the real debates that occurred in the field, and I happened to be the president of the International Society when the first treatment guidelines came out, where the cognitive behaviour therapists were arguing that EMDR is just a form of cognitive behaviour therapy, and the EMDR therapists were saying, no, it isn't. because in EMDR, essentially, you're holding on to the memory of the event and the emotions and alternative emotions that you might have while you're watching somebody's finger being moved. Now, that was thought to be hocus pocus, but, whether the finger movement matters.
It's like when you get, I might get you to explain it for the listeners because it seems like voodoo magic. Like if you try and explain to someone what EMDR is, they think it's voodoo magic. So for the listeners, just quickly encapsulate what's happening in EMDR, just so people understand why it would be viewed as a bit of voodoo magic.
Well, the idea was that you watch the therapist's fingers moving whilst you're focusing on the memory of the traumatic event, the emotions, etc. So the idea that people are waggling your fingers and that's somehow going to make you better was the reason why it was thought to be voodoo magic. But you can see that essentially it's getting the person to hold the memory, hold the emotion, hold alternative emotions. And, one of the other questions was whether this is a form of hypnosis. And that's actually been an important question for criminal proceedings because if you've had hypnosis as a therapy, you're then seen to be an unreliable witness because the hypnosis may have changed the memory of the event for which the criminal trial is being held. So one of the questions is EMDR a form of hypnosis? And because if that is held to be the case, the evidence from the victim who's received the therapy would then seem to be potentially unreliable.
Yeah, I can understand. Yeah.
So, these are interesting scientific questions.
Yeah.
There were a lot of studies done that, I think really suggested that probably the finger movement isn't the important part of the therapy. I mean, one colleague made an interesting observation. He was one of the early people who did the early research on EMDR. He said that, one of the things, because you're getting closer to the patient, you're actually making the patient focus in a way that often doesn't happen because people who don't respond so well to treatments often sort of slip away and sort of dissociate. They don't quite sort of focus. But you can imagine if you're sort of more closely physically engaged in proximity with the patient, they've actually got to stay with the event. And he thought that was one of the really important parts of EMDR.
So that's really interesting because I've never heard the one about the hypnosis before. That's the first time I've heard that one. I've heard a few other bits and pieces before, but yeah.
See, the other thing is the other idea was that you're moving between processing in the left part of the brain, the right side of the brain.
That's all the science I've heard. Yeah.
But again,
I've heard the science.
That takes us back to neurolinguistic programming, and there's been a lot of oversimplification of the lateralization of neural functioning in the two hemispheres. You can come up with some very nice sort of but overly simplistic models. One of the things that we've discovered since we've been using fMRI to measure brain function during specific cognitive tasks, that even with language, which we generally have thought of as a left hemisphere function, is much more bilaterally represented than was previously understood.
Yeah, I mean, even the whole idea of EMDR, how was it even I'm still wondering, how was that even discovered?
Well, the woman, Francine Shapiro,
right,
who brought the treatment forward, claims to have been sitting on a park bench and noticed something in the process of moving her eyes when she was thinking about something depressing or distressing that alleviated her distress. So it was based on a sort of like a self-observation of the person who developed the therapy.
Wow. Now that's fascinating. And therefore and then obviously been taken up and trialled in PTSD and has shown to be quite effective, I understand. Yeah.
But see, another interesting thing about why you get these huge fights between schools of therapy is because she set up a system of training which she essentially ran as a franchise organisation.
Okay, that's why. There's a monetisation aspect here.
Whereas the cognitive behaviour therapists were academic departments of psychology.
Yeah.
So there was a very different sort of model of how you promulgate these schools of therapy, and it led to all sorts of interprofessional jealousy. So I've got to say, one of the really interesting things about being part of the PTSD field, I was the first non-US person to be elected president of the society, was that when this society was in its infancy, there was tremendous antagonism to the field of trauma from the broader body of psychology and psychiatry. So there was a real collegiality, and there were people from all sorts of different worlds, from the military, from the police, from social work backgrounds, from sexual assault victims, and it was a very, very dynamic and interesting group to be part of. But once it grew and started to become more mainstream in specific professions, a degree of disruption to that initial collegiality was lost. And one of the events that did it, I think in the most disruptive way, I was involved as an expert witness in a case where the Falklands Gulf War and Northern Ireland veterans sued the Ministry of Defence in the UK for failure of duty of care during those conflicts. And the defence team and the plaintiffs team had experts, obviously from the field, who'd previously been close friends, but then they were sort of being used to weaponise the arguments against each other, and that put an interesting cleavage into this community.
I can imagine. Yeah, I can imagine. I've also got here neurofeedback. So what role does neurofeedback play? And then I've got here things here around, like, let's talk also about alternatives, maybe something a little bit on the fringe maybe. But let's go to neurofeedback, because you've had a lot of research background and experience in that area. So maybe for those who are listening, just tell everyone very quickly what neurofeedback is and go from there.
Yeah. Well, look, the first thing is that there have been treatment guidelines developed and recommend the CBT, cognitive processing, EMDR as the first-line treatments.
Okay, first line.
Medication treatments as second line. Now, one of the problems is that I think the effectiveness of those treatments has been overstated, and the fact that a number of people are left with significant symptoms hasn't been adequately dealt with in subsequent research. Now, neurofeedback is a secondary treatment, and it's a treatment that's been developed not just for PTSD. It's been used for treating epilepsy, but it's based on the idea that using certain training tasks while monitoring somebody's EEG, you can modify the patterns of cortical arousal that people have. Now, cortical arousal it really underpins anxiety and reactivity. So basically, neurofeedback is where you get people to, for example, watch a computer screen. They can actually learn how to control the movement of images on a computer screen from the monitoring of their brainwaves. So it's intriguing therapy. So, there's a logic to why it works. The treatment trials, I don't think have been as well funded as they need to be, and there's important evidence pointing to its effectiveness, but it hasn't reached the same level of evidence or quality of evidence as for those other psychological therapies that I've talked about. And so it tends to get pushed to one side by those mainstream proponents.
Yeah, I'm gonna circle back, because I noticed that you mentioned the question around medication. So first lines of treatment, prolonged exposure, EMDR. Now the question for medication. Now, please be as honest as possible. What role, if at all, does medication play here in PTSD? Because I've spoken to a few, again, associates, and they've told me when they actually could get in to see a psychiatrist, someone to prescribe, just say certain medication A, B, and C, and others said, no, that's the worst thing you could do with PTSD. And I'm like going, well, if two psychiatrists who, are experts in this field can't agree, I'm like going, wow, what is going on here? So, yeah, sorry, I don't want that to be a loaded question, but that's a real life example right there.
Well, look, it's intriguing that you'd get such divergent opinions. I mean, look, the first thing is that I don't think that literature honestly reflects on the nature of what the real world is. Look, the people who have published the most important studies in this prolonged exposure area, they're colleagues, I know them. I know that a significant percentage of the patients in those trials have been on antidepressant medication. So people will often be stabilised on antidepressant medication before they
do the trial, which kind of makes the trial almost null and void, because how can you isolate or exclude that as part of a variable in the trial?
Absolutely.
Yeah.
And the second issue is that many of the psychotherapy trials have used wait lists as the control to compare them with the active treatment group. Now, with the medication studies, for a medication study to be accepted by the FDA in America, you've got to have an active placebo, or a placebo and a drug, and people don't know which treatment they're getting. And what we know is that the benefit you get from a placebo is significantly greater than you get in the wait list. So you can see that if you compare the wait list with the psychological therapy, there's a bigger difference. But a significant part of that is explained because of the absence of the placebo effect. And the interesting thing is and there's a whole debate on this, when you compare different psychological therapies with each other head to head, you don't get the differences.
Okay.
So now, getting back to your question about medication, why does medication work? Well, it works for a number of reasons. One of the first things is these medications are not just compounds that affect mood. Essentially, I tell patients they're like brain glue. I think I described before how the brain doesn't properly integrate its function. And essentially, these medications, the serotonin system particularly, and the noradrenergic system, are these very long fibres that bind the different parts of the brain together. And so it's a bit like putting the conductor back on the podium, and using EEG-based studies, we can actually show that it actually normalises the integral function of the brain in that way. And another really important thing that serotonin does, it's a bit like if you're sitting in a really noisy restaurant trying to have a conversation with the person next to you, the ability of your brain to focus on the conversation is dependent on your ability to produce serotonin. Now, interestingly, some people produce serotonin more effectively than others do. There's actually a genetic inheritance about the effectiveness of your serotonin systems. So having high levels of serotonin allows you to shut out irrelevant information. One of the things that goes wrong in PTSD is your ability to shut out irrelevant information. So the drug actually just helps you be able to focus. And look, a really interesting experience I had, actually it happened after the Ash Wednesday fires, where I was treating some people who were living in the southeast of the state, and I really couldn't provide them with psychotherapy because I couldn't see them on a weekly basis, and people in the Adelaide Hills. I'll never forget one person saying to me, after I put him on some medication, he said, look, the first thing I noticed, I could start to read the newspaper again. Once he then could begin to engage with his current environment, you can see how that then allows him to attend to where he is rather than to where he was and in the trauma.
Okay.
So, look, one of the things that I often do with a patient will actually show them some of these neuroimaging studies that we've done and say, look, that's what your brain looks like. That's what the brain of somebody without PTSD looks like. And that's the way that these medications can work. But look, I'm not saying, the medication alone is going to solve the problem.
Yes.
What it's going to allow us to do is to then better engage in these psychological therapies.
So how would, I guess as a clinician, how would you then determine whether I should give a patient or prescribe medication to someone and it's beneficial for, say, patient A and it's not beneficial for patient B? I guess that's experience, of course, and training and so on and so forth. But I guess I'm trying to understand that scenario I gave before where the psychiatrist said, no way. Prescribed medication is actually going to make things worse for you. And I was like going, oh, okay, I've never heard that before.
Well, look, there are some medications I certainly wouldn't prescribe. But so again, it depends what medication that's being said about. But look, again, I think that's one of the peculiarities I find about the whole world of the treatment of mental illness, that some people get attracted to particular schools of treatment. Whereas I'd say, look, if you had a carpenter turn up to your house with only a screwdriver in his toolkit, you wouldn't want him to try and, fix your cupboards. You might want to drill in a hammer, and so look, I'm a much more sort of eclectic thinker in that domain.
Yeah, I using, I guess, that story, because I think it's an extreme case. I realise it's an extreme case, but I guess it highlights just the range of kind of responses by psychiatrists in relation to PTSD, and I found that really fascinating when I heard those stories, and I thought that was a perfect question for you. So thanks for answering that one, because I always immediately thought, well, look, there must be a legitimate reason why the psychiatrist would say, no, I don't think that's going to work for you. Obviously no other detail was provided, but I think obviously that's important in order to understand why the psychiatrist would say, no, I don't think it would work for you.
So, look, I think one of the other things that I think we don't talk about enough in this field is the issue of treatment non-response, or the treatment resistance. And so often people will go along and they will have what would be the prescribed number of sessions of psychological therapy, and they've still got significant symptoms. And the therapist will say, oh, we haven't given you enough, so we'll just do more. Rather than actually stopping and saying, hang on a sec, what's the issue here? And we certainly know that, psychological therapies are not as effective with people who've had multiple traumatic experiences. And there are also some very important parts of the traumatic memories that these therapies don't deal with. One very interesting one is smell. People will never have smell being addressed in a prolonged exposure. And there's a lot of evidence it's very difficult to desensitize somebody to smell. If you've got a sort of disgust, vomiting response to a particular smell, like of decomposing bodies, it's very difficult to decondition them.
Yeah.
So, and the field actually hasn't had honest conversations about where we go from that. The other issue that I mentioned was that you've got all of these comorbidities like diabetes, hypertension. And, look, there's some very interesting evidence that there are some families of antihypertensive drugs. If you take those drugs and you look at a population-based study of this, they're less likely to get any form of any different types of psychiatric illness. So antihypertensive drugs, interestingly, have some protective effects against psychiatric disorder. Anti-inflammatory agents appear to have some effects.
Yeah.
So there's a whole raft of things that are not, I think, properly discussed in the treatment literature. And so it leaves a group of people who've had what should be effective care but are still unwell.
Yeah, see, we're only scratching the surface here when it comes to treatment here. So an academic psychologist, not going to mention names here, says to me, there's the third rule going on here. So these first line of treatments that you're talking about, and this is, I guess, my question, I'm going to get to the question is, what's going on here when we've got a first lines of treatment around PE, EMDR, say medication, and there's a third rule going on? For some populations, PE works a third, and then we have a third for EMDR, and then maybe a third for medication. Surely we could do better than that. PTSD's been around for a while now, so what's going on there?
Yeah, well, look, it's a very, very interesting question. Look, I think that there are several things. The first thing is that no medication, for example, has been developed specifically for PTSD. These drugs are always developed for anxiety, depression, etc., and then they get trialled in PTSD. So I think one of the first things and is to, I think, have a much more comprehensive consideration of the neurobiology of this condition and think about, well, if you were going to go back to first principles, what might you do? The second thing is that the academic psychology world is very much captured by the CBT, PE world. And
he was good enough to say that.
And when you do apply for a treatment grant, doing something novel, they'll say, oh, we already know how to treat it because we've got CBT. So, and I've had senior colleagues overseas say to me, I've given up writing treatment grants because they always get reviewed by CBT psychologists who say, look, there's no need to do that because we've already got the problem solved. So I think there's a degree of dishonesty and patch protection in the in the academic world, and I think it's always fundamentally important to admit what you don't know, and for disciplines to admit what they don't know, because that's where advancements in knowledge happen.
Yeah. You know, I thought I had to ask you that question. I call it my third question. Let's go to second-line treatment. So you've spoken a little bit about neurofeedback, and thank you for doing that. I understand there's some great outcomes from neurofeedback, but what are some of the other second line in treatments?
Well, there are a whole range of other psychotherapies.
Yep.
There's interpersonal psychotherapy, hypnosis, was used in the late 19th century, was used on the battlefields of the First and the Second World War. It's still, a treatment that is used by some practitioners. Sometimes people get just supportive counselling, and I think that's another really important thing to say. A lot of people think they're getting CBT and they're not. It's no good just going along and somebody giving you a chat. I think people don't realise that the degrees of professional training in psychologists is very variable. Only a small percentage of them are actually clinically trained psychologists. So I think there's a lot of treatment which actually isn't effective treatment. Just coming along for a supportive chat doesn't sort of cut the mustard here, basically.
Well, I could do that with Turbo down at the pub, you know.
The sort of the other treatments that have been looked at are things like yoga.
Yeah, where would you call them? Like second, third, maybe, or just?
Well, look, I think there's a whole sort of mishmash of therapies that, and not without being sort of disrespectful to them, but you see, because one of the things that we were talking about is the hyperarousal that people get. So if you can have approaches that assist people in being more in touch with their physiological reactivity, and things like yoga and mindfulness psychotherapies, which are another important area where there's been increasing interest, sort of take people in that domain. And look, I think one of the things that the treatment literature hasn't addressed is the raft of physical symptoms that people get with PTSD. Pain is very common in PTSD, difficulties with breathing, gastrointestinal symptoms. These are really, indications of the physiological dysregulation, but they've been completely ignored in treatment. Look, I had a woman did an excellent PhD looking at about 13,000 soldiers, and we can diagnose PTSD as accurately on its physical symptoms as we can on its psychological symptoms. Yet the treatment literature just totally ignores that world.
Wow, that's really fascinating. So that's very interesting. And you see, I've heard a lot of good things about yoga, mindfulness, meditation. What are your general thoughts? I'm being a psychiatrist, I'm going to assume that it's all part of the, it's like an cumulative thing. It's all part of the treatment plans. But I'm interested in your thoughts around what role these. I don't like calling them alternative type approaches, but that's how I view them because they're not really part of the medical model. So I'm interested in your thoughts on that.
Yeah, look, I think what's important is that we don't think that there are single lines of intervention that are going to work here. For the very reasons I've just described. I mean, the whole physiological regulation of people is something that so often gets ignored. And so I think that's where those other treatments come in. By themselves alone, no. And you see, I think it's a willingness to say, look, this CBT might work for 60% of the symptoms. But then to ask the question is, what are the symptoms that are left over? For example, disturbances of concentration and irritability are two symptoms which very commonly don't respond to those other therapies, but they're really very disruptive for people's lives. So it's actually, I think, honestly looking to, what it might assist people in those other domains.
Yeah.
And not doing this in a sort of an overly sort of protective or prescriptive way if you belong to one of those schools of treatment.
Yeah. Now, I'm going to ask you a hard question now. And the question, inevitably, there'll be people out there wondering, can you be fully cured if you have PTSD?
I can answer that question, based on people I've had the privilege of working with. Look, there are some people who can live their lives pretty well, much as they did before. But the point is, if you've had some horrific car accident where your wife's been killed in the seat next to you, you remain changed for the rest of your life.
Yeah.
Now, you mightn't have nightmares about her death every night or have horrific images of her when you get in the car every day. And you might be able to fully engage now in another relationship.
Yeah.
So you can be. But the other part of that is that, and I've described the disruptions of your biology, you can never fully undo that. It's like you can't unage yourself. And I sometimes, well, look, there's some evidence that, if you've got PTSD, well, there's more than some evidence that you lessen your life expectancy by about 4 years.
Wow.
And that's to do with these sort of inflammatory shifts that occur and this physiological dysregulation. Now, the extent to which we can reverse that, part of it's also about the methylation of certain genes. I'm not sure if people are aware that, that our genes don't just automatically work based on our genetics. Environmental factors lead to genes being switched on and off, and that's called methylation. And you can actually look at people who've been exposed to stress and show how the patterns of methylation of their genes change. And you see, there's no evidence that I know of that treatment can turn those methylation processes off.
Yeah. I guess it's a bit of a cheeky question, really, because it really depends on what you mean by cure, right?
Yeah.
So for a lot of people, if that means they can function when in the past they couldn't, I guess that is a probably form of. I'm very hesitant to use. I know the term cure is part of the medical model, and I guess when I heard you answer that, it was more around, well, I guess it depends on, whether you are functioning or not. So if it means you can then function, well, then that might be enough. For some people.
That person won't have the diagnosis anymore. But, they still are they are a changed person.
Yeah.
And look, can I just also make a point here? Look, it's very easy to think, if you've had PTSD, it's terrible and your life's ruined, et cetera, et cetera, et cetera. But look, I've got to say that, I've dealt with people who've had, a raft of dreadful adversity happen to them. And look, I think a great deal of wisdom and contribution to society in very positive ways is made by people who've faced realities that most of us could never imagine. And I think, the willingness of societies to see dreadful adversity and to try and understand it can give everybody a great deal. And if you think about even safety measures, often the people who've advocated for particular safety measures in our society are people who've suffered terribly, and they can see a consequence that most other people deny.
Yeah. Yeah, definitely life's not over. My associates I was telling you about before, they would be what you'd happily call high functioning. Life's not over, definitely. So if anyone's listening to this who suffers from PTSD, definitely life's not over for you, that's for sure. Look, I have to ask this question now is around prevention. Now, so if I am a first responder and I have to, obviously keep fronting up, look, are there anything that we could do to protect ourselves, maybe prevent, this maybe from happening? I mean, I don't even know if that's even possible, but I've got to ask you. I have to ask it, Sandy. Yeah.
Okay. Look, it is everybody's dream.
Yeah.
It would be fantastic to come up with strategies and techniques where you could teach people how to make themselves immune to the effects of these dreadful events.
Yeah.
And there's a great deal of sort of discourse at the present time into wellness and well-being strategies, particularly in the health domain. The trouble is that the evidence for it, and look, and I don't want to be cynical about this, but people have really tried to study this stuff, and the evidence that many of these interventions that a lot of money gets put into are effective is actually pretty weak. Look, the Institute of Medicine, which is the equivalent of the NHMRC, the National Health and Medical Research Council in Australia, did a review for the US military, it would be about 10 years ago now, into possible prevention programs for soldiers. And a great deal of effort had been put in by various military units to, investigate different techniques. But they came to the conclusion that the evidence that any of those prevention techniques had much effect was pretty minimal. The only thing that they identified was the screening, the regular screening of personnel, because people don't suddenly wake up one day and they're unwell. You get this slow, progressive recruitment of symptoms. It's a bit like asthma. If you're exposed to an allergen in your environment, the reactivity of your airways increases the more you're exposed to that allergen. And the issue is, how do you then dampen that reactivity? And one of the things you would stop doing if you had asthma would not to be expose yourself to the allergen. And so, the issue is, if your symptoms reach a certain level and you're in one of these high-stress jobs, you need a bit of time out. So, look, I wish there were things. I mean, it would be very interesting to see whether you could use strategies such as EMDR or that has been and not really been found to be effective, but neurofeedback, etc. If you did start to notice somebody's startle response being increasingly reactive, whether you could decondition them with that.
Yeah.
But there's a great deal of work here. But I think the problem is that so often bureaucracies become wildly optimistic about prevention without the evidence.
Yeah. Because it does, like, even when I was posing the question, as I'm sure you could tell, it just seems a little bit unrealistic, this kind of the idea that you could protect yourself, like in the sense of a, preventative measure, as in like not get it at all. Like, I mean, as if that's even possible with, like it's almost like saying, I can't predict the future, Sandy.
Yeah.
Of course you can't. So but I understand why organisations would care about this, police force, ambulance, obviously defence force, people who are definitely going to be dealing with traumatic events on a regular basis. I can understand why that question really would be front and centre. I really do.
It's and as we talked about before, in those sorts of roles, teaching people competent skills and how to manage extreme situations. I mean, we often talk about these situations as being uncontrollable stress. But even in the most extraordinary circumstance, how to manage your survival is a very, very interesting and critical skill.
Yeah.
And I think, so often, we think that, look, you're absolutely unable to do anything. But, I think it's one of the things I've always found fascinating about the lives of astronauts. People like Neil Armstrong had been in a number of extremely dangerous and life-threatening situations.
And yet he was so calm. It was incredibly, like I've heard a couple of interviews of him talking, and you go, he was so, I still can't believe how ice-cold calm he was.
Well, he when he landed on the moon, they had 60 seconds of fuel left. And I was once at dinner with a test pilot and the head of the Defence Force who'd been a pilot. It was not long after he had died. And I said, what was the least fuel you ever had when you landed? And they said 10 minutes. And he was about to land on the moon for the first time and had the whole world watching him and had all these alarms going off.
Yeah.
And he managed to do it. See, that is the sign of a person who can control himself and control his systems. But how you predict that is incredibly difficult. But apparently he virtually never flew again after going to the moon.
No, I didn't know that.
He became a professor of engineering.
Oh, no, I didn't know that. I thought there was a little bit more to that story. But I just there are other stories too before he did go to the moon of where he was testing different aircraft. And lost control and bailed out and just calm under pressure and, what we would say calm under pressure. But because I always immediately go, well, what part of that is training and what part of that is disposition, as in him as a person? Clearly it's a combination. You can't say which one is obviously, more at play than the other. It was just, it's a combination of things, and that's what you were saying before about the screening. Yeah. Clearly that matters, in terms of personality. Is certainly a contributing factor around risk factors.
I got my notes here. Training is the other really interesting part of this. Is that one of the things I always intrigued by is having worked as a doctor early in my career. I guess I've also dealt with an extraordinary number of horrific sort of details and information. I mean, I've looked at all the records of torture in Iraq.
Yeah.
But the point is, if you've got a particular training and spectrum, it can allow you to deal with things. So that I think we should never underestimate the importance
of training. Yeah.
Of training, and because it does give you a lens to understand.
Yeah, actually, that's a good question. I hope you don't mind me asking a personal type question, but you've obviously dealt with patients, some unbelievably traumatic events. You've obviously looked at case files and done research. How have you protected yourself from getting, say, PTSD, for instance?
Look, I think that's an interesting question. Look, I'd say one of the things that I've found an enormous privilege, well, firstly, to be a clinician, to share, the most extraordinary and intimate reflections of people, and to learn about a spectrum of life which, thankfully, most people are protected from. Look, I think because I, was also an academic, I could then use that experience to drive the areas of research that I undertook. But also another very important part of my professional life has been advocating for people. Partly that was through medico-legal work, but also in leadership roles and dealing with health authorities. I think it's really about being able to not just sit with those horrific stories, but to use that experience and to try and sort of transform systems for people. I think. And look, I guess I think I haven't gone unchanged. If I drive a long distance, I always think there's, when I interviewed police who motor accident investigators, I always ask them what are the three things you should do on the road, and I'll think about those things when I drive, and I think I mightn't get there, but I'll still do it.
Yeah.
So it's like I think I also have a much more highly developed sense of risk than most people do.
Yeah, I can imagine.
But it doesn't stop me going sailing in dangerous places and doing things that are fun.
Yeah.
But I think the one place that has got me into difficulty actually has been in bureaucracies, because I think I will see what's going to go wrong earlier than most people do. And people don't like the naysayer.
Yeah, I'd agree with that. We might talk about that one a little bit offline, I think a little bit, but I hear what you're saying, definitely. Now, I'm conscious of the time. You've been very generous with your time, and I appreciate it. Now, I've got a couple of questions, and then we will be finished. All right, and here we go. So next question I've got is, I will go 2 or so questions, and then we'll wrap up. So what research directions or innovations in PTSD treatment are most exciting to you? Yeah. Like what do you see as the future of PTSD in terms of research and innovations and stuff like that?
Well, look, I think the whole field's going through a bit of a crossroads at the present time, and it's through the psychedelic-assisted psychotherapies. Now, look, I think the enthusiasm is ahead of the science, but I think one of the reasons why this has arisen is because, as I was describing before, it's like there's been this constriction by the cognitive behaviour therapy world, and there's a whole group of people who think, look, we need to be doing better than this. So it's almost been an alternative sort of advocacy movement. Now, what comes out of that, I think, is going to be very interesting. But the other one that I think is an area that is hopefully not too distant on the horizon is, look, there's been generations of really good neurobiological research, but there's not a single conversion of that into a therapeutic intervention. And particularly with artificial intelligence, you can now look at metabolic pathways and you can actually track back from what you identify as the metabolic abnormalities to the particular pathway that is the origin of that metabolic abnormality. And I'd be surprised if AI doesn't really lead us in some very new directions.
Oh, well, it's because I've got a question here around technology from a listener. I'll get to that in a minute. But so that's fascinating because you've mentioned some of your studies and about some of these biological markers, and I agree. As you can see, I've got my Fitbit on, and so you can see how through the use of AI, there's possibilities of tracking your bio kind of metrics over time, and it's amazing what technology can do. So let's go to that question. So I was contacted from a Mr. Seko from Bangkok, Thailand. He's a student and knew about this interview, and he asked me this question here, which he wanted me to ask you was, so when conducting research on PTSD, he was asking a question around digital technology interventions or technology in general, and he's got here a particular question around what role it has to play. And he's got here something around virtual reality or mixed realities. Have you heard anything? So let's put this down as a question around technology that includes virtual reality, mixed reality, even AI, because I know you mentioned it before. So there's a question around.
Look, actually, a colleague, Professor Eric Vermetten, has developed a very interesting intervention using virtual reality where, and it's a form of exposure therapy, but they'll actually construct a virtual lab of the combat environment, for example, that a soldier was in. And then they'll put the soldier on a treadmill and walk them into the reality, this realistic reconstruction of the traumatic event that has led to them becoming unwell. Wow! So it's an absolutely confronting form of exposure.
Yeah, and you could see how it fit under that prolonged exposure, kind of treatment approach.
And look, that's an effective treatment, and I think, really important one. The other interesting thing about that treatment, which is a significant innovation, is that, being frozen in fear is terrible for people. When there was no movement on the trenches in World War I, that's when there were very high rates of psychiatric casualties. Once the front was more mobile, the rates of psychiatric casualties dropped. Yet we sit people in chairs and talk to them. So this colleague has actually put them on treadmills. So they're actually walking. And actually it's fascinating when you ask philosophers about where they get their great thoughts from. It's while they're walking.
Yeah, exactly. In fact, interesting you mentioned Nietzsche before, but there are other well-known philosophers who've been very open about some of their best ideas came from walking.
Yeah, and Elgar was a great cyclist when he was composing. I mean, so look, that's, I think virtual reality is an important area that is being investigated. Look, I think other important areas with technology are there are now even apps, for example, which track people's communications. Now, I haven't spoken about this before, but we know that people lose part of their capacity for language when they get PTSD. The complexity of their vocabulary changes. And you can actually measure that on words like the Boston naming test. And there's been some attempt to actually track people's language and usage language as to whether they're becoming symptomatic or not.
Okay, that's interesting.
So and again, I think that's very much getting into the AI world. But, and look, the physiological dysregulation of PTSD is one that I think is just begging for these sorts of technologies to get involved in.
Yeah, I know. That's good. No, thanks for that. All right, so we're on the home stretch here. Now, if anyone's listening here and they're interested in learning more or reading more about PTSD, look, is there anything you would recommend? And feel free to plug any of your own work here, but, is there like one or two books that are must go-tos, like if they wanted to read something, say, on PTSD?
Yeah, look, you mentioned my dear friend Bessel van der Kolk and his book, The Body Keeps the Score. Now, look, I think that's a very encompassing and engaging sort of personal and professional journey that sits slightly to the side of the mainstream. There are some people who don't entirely sort of embrace Bessel's ideas.
Now, thank you for raising that, because that was my follow-up question to that. What is controversial about, so this is perfect now. You've taken me exactly where I wanted to go, because I've read the book, as you know, I've got it here with me, but yet it's controversial. And I was like going, what's controversial? I don't understand. What's controversial about it?
Look, I think some people would say that Bessel is often 3 steps ahead of the evidence. And he's advocating things where the argument and the evidence remains open. Now, I've got to say, it's one of the things I've greatly appreciated and enjoyed with my life with Bessel is that we've, explored and shared many ideas, and he has got an open mind. But there's some in academia, who feels that he's sort of moved to advocacy rather than evidence. Okay. But look, we wrote a book together in 1996, which sold over 70,000 copies, called the Effect of Overwhelming Experience on Body, Mind and Society, and that's still selling. I mean, and it's one of the things that's fascinating is to go back and read that book, because it tells you in some ways how not a lot's changed in 20 years. There was an incredibly energetic and explosive development of knowledge in the first 20 years of this field, and it's become a bit sclerotic, I've got to say.
I'm going to track that down. I'm definitely going to track that down and read it, and we'll definitely make sure that we list it in the episode description. Definitely.
But look, a more factual sort of summary of the more academic world, which is not totally sort of for the academic, is a PTSD handbook, which is edited by Friedman, Schnur and Keene. That's in its 3rd edition, and that's, got experts from all the different domains of the field with chapters in there, and that gives a very thorough sort of discourse.
Yeah.
But there's some really interesting historical books like Trauma and Recovery by Judy Herman, which was published in about 1990, which still remains a really important sort of historic monograph.
Yeah. Sandy, I feel like we could keep going here. We could talk for a lot longer, but we're running out of time. And the last question I always ask my guests is, do you think we've missed anything on this topic?
Look, I think this is a field that has had an effect far greater than was ever anticipated when we were a small group of sort of struggling professionals with a shared interest. And I think there's always a risk of being the victim of your own success. And as I described at the beginning, there was an enormous interest in learning around this field in 1890 that got forgotten. And it was because there was a societal reaction about it being excessively inclusive. Like the term was removed from nomenclature at a meeting of the German Psychiatric Association in 1916 in Munich because it was seen to undermine the war effort. And we've seen a little with Trump. Trump's trying to stop grants in the trauma field in the US. I've got colleagues who are openly under attack at the moment. And I think if the term and the construct gets overly used and used to explain too much, it is weakened. So I think that is a real risk. Look, I think the other thing that I would say is I always had the sort of anticipation that once a piece of research had been done and a question had been solved, that people would move on to the next thing and that information would be used. One of the things that I've been really troubled by is the lack of use of knowledge and information. You know, even with huge bodies of research, I did a study of the entire Defence Force in 2010, the ways in which that information wasn't used by bureaucracies is profoundly troubling. And I think we are at an age when narratives, often politically driven, have come to replace the importance of knowledge and evidence that's derived through good research. So that, you know, I think we're at a very interesting point where we shouldn't assume that it's always progress that's going to occur.
Mm. It's interesting as you say that. I'm interested in your thoughts. I know you mentioned there's a bureaucratic element that gets in the way around the usage of this excellent research. Beyond the bureaucracy, the big machine, and how inefficient and all those other and the politics that inevitably goes on there, what else do you think is going on there? Because I too wonder the same things. That how is there's inability to take what we already know and then put it into action, I guess, really. And if I'll use the example, obviously here we're talking about PTSD, but what I'm interested in your thoughts. What do you think's actually happening there? What's going on?
Well, look, you know, I've been involved in 6 Royal Commissions in my career. The most recent one is the Royal Commission into Veterans and Defence Suicide. And I think systems have become systems of administration have become much more managerial. I think there's a belief in there being generic management skills that can organise society, and essentially that undermines the value of knowledge and technical skill. And I think it's almost as though professionals have been increasingly diminished in public life. And I think, you know, it's a dangerous state. So it's almost like apparatchiks in systems. And interestingly, I've seen this happen to politicians at the hands of bureaucracy as well. And look, trauma is one space which is very much in the public domain like this. And, you know, I've got to say it troubles me enormously because, and look, I think partly it's to do with the world of Facebook, where everybody can have an opinion about something. And what that allows people in authority or running organisations to do is to just see everybody's opinion as equal, and they just can pick and choose. The value of knowledge that's derived through academic thoroughness and effort, I think doesn't hold the same value as it used to.
Or even the notion of expertise, you know, like yourself who've spent decades in a particular field and is an expert in that particular field. I mean, why wouldn't you listen to the expert? Like if you are commissioning someone and asking them for their opinion and getting them to write reports, at the end of the day, I ask the question, why wouldn't you action their recommendations if there are any recommendations? I just, you know, I guess that's why I asked the question around the, you know, what's happening in the bureaucratic level, what's happening at an organisational level. I know we hadn't had it on our list here of things to talk, but I couldn't help but ask you as someone who's been up against this for a long time.
Well, just one last comment on that is, look, obviously I've been involved in multiple disasters and writing reports around disasters. Disasters are infrequent occurrences, and you have to learn from the last one if you're going to survive the next one. And the Royal Commission into Natural Hazards, which is chaired by Air Chief Marshal Binskin, who'd previously been head of the Defence Force, one of the things it looked at was the inability to retain knowledge and information. And I think because there's so much information now, I think systems are less able to actually look at historical lessons and themes. I think it's almost like people are overwhelmed by the current.
Okay, that's interesting.
And can't look at context and value the temporal depth of learning.
Yeah, or even nuance too. Yeah, so that's very interesting. I think there's a lot to be said there, because we almost have the opposite now, where we have way too much information and we don't know what to do with it in terms of sift through and use what's actionable, to use I couldn't think of a better term, but at least when I say actionable, you know what I mean, as in what can we use and what is not actually useful in certain, kind of contexts, situations and scenarios. So, look, I think we could talk on for a while here, but I'm conscious you've got to go here. And look, this is such a fascinating area. I did say before off air that I'd have a lot of questions. You've been very generous with your time. You really have, and I know you have to go. And we might leave it there for now, but I want to say thank you, Professor Sandy McFarlane, for your time. You've been very generous with your time. And I want to say thanks for joining me today, and we'll leave it there for now.
Oh, well, look, it's a privilege, and again, I'd like just to acknowledge all the people who've been through these terrible experiences who, I've greatly valued what they've taught me, and I'm here because of them.
And that wraps up our interview with Professor Sandy McFarlane. I don't know about you, but I'll never look at trauma the same way again. From the battlefield to the science, Professor McFarlane has taken us on a fascinating journey through the landscape of PTSD. Before we go, I want to extend my deepest gratitude to Professor McFarlane for pulling back the curtain on this often misunderstood condition. Your work isn't just changing textbooks, it's changing lives. To everyone listening who might be battling their own invisible wounds, or maybe you're just supporting someone who is, I just want you to remember one thing: you're not alone, and there's hope in the science we've discussed today. If this episode resonated with you, hit that subscribe button and maybe share it with someone who needs to hear it. The conversation about mental health only gets louder when more voices join in. Until next time, stay curious, stay compassionate, and think deeply. And remember one thing: understanding trauma is the first step toward healing it. This has been Deep Thinking with Dr. Stephen Stolz.